Okay, this is risperidone, which causes hyperprolactinemia. So these patients, paranoia, social isolation, disorganized behavior are suggestive of psychosis. She is likely being treated with antipsychotic medication. Antipsychotic medication cause dopamine blockade because of dopamine is a prolactin inhibiting factor. Dopamine is a prolactin inhibiting factor. The blockade of dopamine in the tuberoinfundibular pathway can lead to hyperprolactinemia, and symptoms such as gynecomastia and galactorrhea, menstrual dysfunction, and decreased libido. Risperidone is commonly used in the second generation antipsychotic that is known to have a high frequency of prolactin inhibition is likely responsible for patient symptoms. It is not prolactinoma. Prolactinoma are benign pituitary tumor that typically comes with headache, visual disturbance. Women in those not have, and they have a very high prolactin level, more than 200, whereas medication induced related hyperprolactinemia is typically in between 25 to 100. She has vomiting, abdominal pain, weight loss. Sorry. Sorry. No, just thinking that way. Everything actually fits for primary adrenal insufficiency, like hypotension, vomiting, abdominal pain. But the thirst part, like he has excessive thirst, where we find in excessive thirst? Sorry, no aldosterone. No, like if there is diabetes, then decay, like diabetic ketoacidosis in their mm, okay. First box, diabetic ketoacidosis, young age, brittle type 1 diabetes mellitus, and maybe a manifestation of diabetes. Clinical symptom acute or subacute onset, initial polyuria, polydipsia, blood vision, weight loss, later alternmentation, hyperventilation, and abdominal pain. Diagnosis glucose is high, more than 300 to 800 milligram per dl, metabolic acidosis, low bicarbonate, and increased anion gap, and positive serum creatine, high flow IV fluid, IV insulin, and follow and replace potassium. This patient's presentation suggested diabetic ketoacidosis from a new onset type 1 diabetes mellitus. Decay was likely triggered by her recent GI illness, nausea, vomiting, which exaggerated which exacerbated dehydration and precipitated ketoacidosis. Features of these patient's illness consistent with decay include young age, although type 1 diabetes mellitus is classically associated with childhood onset. One-fourth of the new cases are diagnosed in young adults. Decay is the second most common initial presentation of type 1 diabetes mellitus. Symptoms: rapid onset, weight loss, polydipsia, and diffuse abdominal pain occurs possibly from acidosis and electrolyte abnormalities impairing the GI function. Delayed gastric emptying and ileus. Clinical sign: dehydration evidenced by tachycardia and hypertension and hyperventilation. Compensation for metabolic acidosis are prominent. Therefore, checking fingerprint glucose is the appropriate next step in the management. This test is rapid and minimally invasive. It can narrow the differential diagnosis and initial treatment for this patient's GI symptoms and lethargy. Glucose level 300 to 800 milligram per dl should prompt empiric treatment for decay and confirmatory testing serum ketone and ABG. Okay, why it is not choice B? Abdominal pain, hypotension, and vomiting can be seen in primary adrenal insufficiency, diagnosed via tropin stimulation test. However, adrenal insufficiency is unlikely to explain polydipsia and hyperventilation. Moreover, it is associated with hypoglycemia. Assessing finger check glucose is more optimal approach to narrowing the diagnosis. And okay, next. Primary, is she has primary adrenal insufficiency? Sorry, maybe you are right. Hmm, yes, maybe Shihan, because significant hemorrhage that required multiple transmission. She is unable to. So it is Shihan syndrome. Sorry, sorry. Uh, acid, everything is low, like pituitary problem. Sorry, ACTH, not pituitary. ACTH may be high. ACTH, yes. Oof, what happened to me? Then ACTH and the sodium may be low, as because blood pressure is low. I was thinking in different way, but my thinking was correct too. It is secondary. She, yes, is secondary adrenal insufficiency. Oh, in secondary eldo. Okay, I'm reading the explanation now. This patient has Sheehan syndrome, which is caused by anterior pituitary infarction in the setting of PPH. The anterior pituitary blood supply operates through the low pressure portal system, making it susceptible to ischemic injury with reduced perfusion. In contrast, the direct arterial supply of the posterior pituitary gland renders it and its secreted hormones ADH and oxytocin more resilient to hypotension. As in this patient, manifestation related to loss of multiple anteropituitary hormones include lactation failure, loss of prolactin, dry skin, fatigue, decreased TSH, decreased body hair, like central hypogonadism from loss of FSH and LH. In addition to central or secondary adrenal insufficiency due to decreased ACTH, adrenal insufficiency is characterized by cortisol deficiency. It presents with GI symptoms, abdominal pain, nausea, anorexia, and loss of vascular tone, orthostatic hypotension. In addition, because cortisol acts as an inhibitor of ADH, the decreased cortisol in adrenal insufficiency often leads to hormones SIADH release in with hyponatremia. Although these features occur in both primary and secondary adrenal insufficiency, further manifestations differ on the site of the hormone deficiency. In primary adrenal insufficiency results from destruction of the adrenal cortex. So ACTH is high, the patient is hyperpigmented due to co-secretion of MSH with ACTH, and aldosterone deficiency, hyperkalemia, salt wasting, volume contraction, and hypertension. In central uh, adrenal insufficiency, Sheehan syndrome results from disease of the pituitary or hypothalamus leading to a deficiency in ACTH. Skin hyperpigmentation does not occur because the adrenal cortex remain intact. In Shihan, aldosterone synthesis is regulated by the RAS, is unaffected, and the potassium is normal. Hypotension can occur but mild. So in here in central there is deficiency of the ACTH, so skin pigmentation does not occur, and as adrenal cortex is intact, the aldosterone synthesis depends on the RAS system, so it is unaffected. That's why potassium is normal and hypotension can occur but is mild. Got it? Sodium is low because aldosterone is retaining sodium. Aldosterone, what does the aldosterone do? Aldosterone is retain sodium and excrete potassium ion, isn't it? So as your RAS system is activated, the RAS system is activated, so renin comes, aldosterone comes, so sodium retention happens and potassium excretion is happen. So more and more sodium is retaining, so low sodium and kind of high potassium may be present, but potassium level is normal. Sorry, should be okay. In this explanation, sodium should be like higher, not lower. Yes, you are right. If sorry again. Yes, if it's ADH, ADH will just retain water. No sodium is involved. Low ADH means low water. So if low ADH, then there may be high sodium. So like your explanation is, as there is low cortisol, so more and more ADH comes and it is diluting the sodium level. That's why there is hyponatremia, like dilutional hyponatremia. Maybe. Yes. ADH. Okay. Yes. Okay, this teenage patient has difficulty concentrating as well as loss of interest in activities and relationship symptoms that often suggest a mood disorder depression. However, depressive symptoms are non-specific and and warrant a thorough history of physical examination to assess for underlying medical condition, hypothyroidism, vitamin B12 deficiency. In this case, this patient also has constipation, bradycardia, and raising concern for acquired hypothyroidism. The most common cause of hypothyroidism in adolescents is autoimmune thyroiditis, in which immune-mediated thyroid gland dysfunction impairs thyroxine synthesis. Hypothyroidism leads to generalized hypometabolic state in children. Similarly, in adults, often makes a fatigue, constipation, bradycardia, and cold intolerance. Mood and cognitive symptoms are common in adolescents, often include declining school performance, as seen here. Features of hypothyroidism that are unique to children include declining growth velocity or short stature and delayed puberty. Therefore, thyroid function test should increase TSH and decrease free thyroxine level. And most patients has elevated antithyroid antibody, antithyroglobulin, antithyroid peroxidase. Treatment with levothyroxine typically results in improved depressive symptoms. Got it? Okay. This patient has firm unilateral breast mass concerning for breast cancer. Klinefelter syndrome is associated with testicular fibrosis and is common cause of primary hypogonadism. Testosterone production is reduced and the compensatory increase in gonadotropin causes increased expression of the aromatase, leading to increased conversion of testosterone to estradiol and elevated estrogen or androgen ratio. In the breast, this causes gynecomastia and elevated risk of breast cancer. Initial evolution of suspected breast cancer in men is similar to that for women and includes breast imaging mammography. Characteristics feature can distinguish benign gynecomastia from malignancy. Can have gynecomastia can have variable density but is typically symmetric and centrally located with respect to the nipple. It may have an indistinct margin with surrounding fat. In breast cancer, the mass is more likely eccentric, off-center to the nipple. It also more likely to have well-defined or speculated margin and may contain calcification. The diagnosis can be confirmed with biopsy, fine needle aspiration, core needle biopsy. Invasive ductal carcinoma is the most common histologic type, as in this woman, and most tumors are hormone receptor positive. Okay. Just look at the features. Like this patient has constipation. This patient has weight gain. There are two features, and another there is hypercholesterolemia, and hypercholesterolemia happen in, yes, hypothyroid cause hypercholesterolemia, and his and her BP is actually slightly higher, like 130 over 90, not 140 over 90, but 130 over 90. It will very soon go to hypertension. Okay, postpartum thyroiditis occurs 7 to 8% women after childbirth, usually within first 6 months. Patient can have brief hyperthyroid phase due to release. Patient can have brief hyperthyroid phase due to release of preformed thyroid hormone, but frequently have only mild non-specific symptom, anxiety and palpitation. The subsequent hypothyroid phase, fatigue, weight gain despite normal appetite, constipation often brings patients to medical attention. Examination typically shows non-tender goiter, bradycardia, diastolic hypertension, low extremity edema, and other findings. Coarse faces, delayed tip tendon reflex relaxation. In the hypothyroid phase, TSH will be elevated. and T4 will be low. Other lab associated with hypothyroidism include hypercholesterolemia due to thyroid effects on lipid metabolism and hyponatremia. Postpartum thyroiditis is similar to painless thyroiditis, but by convention the latter is not diagnosed within a year of childbirth. Both may be considered variants of chronic lymphocytic Hashimoto thyroiditis are associated with elevated titers of anti-TP antibodies. However, whereas Hashimoto thyroiditis frequently leads to permanent hypothyroidism, postpartum and painless thyroiditis are usually self-limited, and patients may return to euthyroid state over several months. Okay. Is it primary adrenal insufficiency? Okay. Okay, from the second part, which is very important, the secretion of ADH is increased. The secretion of ADH is increases primary adrenal insufficiency. This results from both non-osmotic stimulus for ADH release. This results from both non-osmotic stimulus for ADH release in the setting of hypovolemia and reduced inhibition of the ADH in the setting of reduced cortisol. With increased ADH secretion, there is increased water retention. Increased water retention leads to hyponatremia. Yes, and aldosterone deficiency leads to renal potassium retention. Aldosterone deficiency also leads to renal potassium retention. Therefore, hyperkalemia is usually present as well. Okay, can you describe these 2 points? The secretion, from the secretion and as well, like whatever we read. Yes, yes. Okay. Question 3. Okay. Okay. Yes. What does he have? Primary adrenal insufficiency. Sorry. Which one is increased in this patient? And 17 hydroxy progesterone. That means 21 hydroxylase enzyme deficiency. Sorry, what would be? Eh, then 17 would be high. Yes, it is the right. And in 21 hydroxylase has salt wasting property along with the uncirculated bilateral testis in the scrotum. Maybe. Sorry, but there is a salt wasting in classic congenital adrenal hyperplasia in 21. It has salt wasting property. In here, sodium is low, potassium is high. This is one of the salt wasting. But as the baby is too small, so we are not seeing the abnormality in the genitalia. Like, isn't it? Okay, partially. Okay. So this patient has classic congenital adrenal hyperplasia caused by 21 hydroxylase deficiency, which results in inhibit conversion of progesterone to 11-DOC, a precursor of aldosterone. Decrease aldosterone causes dehydration, shrunken, fontanelli dry mucus, and salt wasting, hypertension, hyponatremia, hyperkalemia. And inhibit conversion of 17-hydroxyprogesterone to 11-DOC, a precursor of cortisol. Decreased cortisol result in fasting hypoglycemia. And increased conversion of 17-hydroxyprogesterone to androstenedione, a precursor of the testosterone. Increased testosterone causes virilization with ambiguous genitalia in female infant, and male have no abnormal newborn genital findings, although they may have enlarged penis or scrotum. Hyperpigmentation. So newborn screening allows early detection of classical congenital adrenal hyperplasia, and a significantly elevated 17-hydroxyprogesterone level confirm the diagnosis. Treatment involve glucocorticoid and mineral corticoid replacement. Okay, okay, can we stop here? Okay, okay, bye bye.